So we constructed the theory on the basis that the shock would hit the body in a sense before the thinking brain caught up, before the feeling brain even caught up, because there's no affect yet activated. And it looks as though we can have these shock responses probably within 100 milliseconds, maybe even 50. So they're so fast, they're easily missed. And they're so fast, it's easy then to go into the affect that takes over, because who doesn't get distracted by being terrified? You're not going to think about whether your shoulders are braced. You're going to think about the terror and what to do about that.
The Neurofeed podcast. From the intersection of neuroscience and therapy, these interviews with therapists, researchers, home users tell stories of discovery, empowerment, and learning to thrive. Today, we're looking at deep brain reorienting. Our guest is Frank Corrigan, formerly an NHS Consultant Psychiatrist specializing in the treatment of post-traumatic and dissociative disorders. Dr. Frank Corrigan is now in private practice. He's author and co-author of multiple important texts about trauma, neuroscience, and therapy, and joins us to discuss a paradigm shift in the field of trauma recovery. In this interview, I'm joined by author and pioneer in neurofeedback and therapy, Sebern Fisher. Illuminated by his research and clinical process, as a growing number of clinicians are discovering, with deep brain reorienting, it is possible to access the earliest moments of shock from trauma recorded in the brainstem, and by gently slowing down and anchoring to empower survivors to clear these wounds without the overwhelm and dysregulation often triggered by reliving these terrible memories. So I had a handful of questions, and Sebern, I know, has some questions that she wants to ask you. One of the ones that we talked about to start with, Frank, was just a little bit about, well, maybe Sebern, do you want to frame it the way that you were describing it to me, the medical school and that sort of the questioning about that, like how did you get where you are? We can't hear you. You're muted, I think, Sebern.
So what we were imagining, Frank, before you came on was you in medical school learning psychiatry. You probably didn't learn very much about the brain or the brainstem. You may have learned the chemical domain. I don't know what you learned in medical school, but I doubt it's what you're teaching now. And I just wanted, if you would, give us a little bit of a glimpse of what journey you went on that first got you to come to the brainstem, which is one radical thing, then to attachment shock as the core issue in trauma that you are dealing with, and then to DBR as a way to work with that. So that's probably your biography, but yet to be written. But if you could just talk a little bit about that that course, I would love to hear it, because I think that's what we're all being attracted to in your thinking. And you had to get there on your own. You didn't have a Frank Corrigan to take you there. So if you could talk to us about that, I'd love it.
Okay, that gives me a fairly wide remit here. When I started studying psychiatry, I was already interested in ideas about the unconscious, and in medical school I spent a lot of time reading the collected works of C.G. Jung, when I should have been better employed in studying pharmacology and other things like that. But anyway, I got through medical school and retained an interest in the unconscious and in ideas about the unconscious, but was really curious about what structures in the brain that could be based on. So when I was reading about archetypes of the collective unconscious, for example, I was wondering what structures in the brain would be involved in predisposing to certain patterns of thinking or feeling or believing. So, but that was at the back of my mind for much of my early years in psychiatry, because the most important thing was the development in psychopharmacology. So I was really interested in the new drugs that were coming out and how they made treatments better for people, how we were able to treat conditions with fewer side effects and better outcomes. And so much of my general psychiatry was really about fine-tuning drug doses and drug combinations and trying to get drug regimes that were optimal for people to still function well and have a good quality of life with minimal side effects and minimal intrusions of their conditions. And that was great for schizophrenic illnesses, it was great for bipolar illnesses, but for complex trauma disorders, it just didn't work. And my interest in finding some effective treatment for complex trauma disorders was partly because of the severity of them, because of the intensity of the suicidality that was often present with the complex PTSD, and also because of the failure of all these wonderful drugs to really improve mood, reduce flashbacks, reduce intrusive thoughts, and overall improve the quality of life. So I found myself using combinations of drugs that reduced symptoms to some extent, but really did not get to the core of the disorder, did not really help the suffering that was at the core of it. So that led me into different treatments, such as dialectical behaviour therapy back in 96 or thereabouts, and then EMDR in 99, and then sensory motor psychotherapy, clinical hypnosis, brain spotting, comprehensive resource model. So the pathway was always aiming to find effective treatments for complex PTSD, especially for those who had intense suicidality. And simultaneous with that, I was always thinking about what was happening in the brain in people who were suffering, what was happening that was intensifying the suffering, what was the impact of early life events that persisted and made that suffering continue to be intense and severe and lead into suicidality. So a number of hypotheses, many of which I had to reject quickly, but at least hypotheses can be tested and discussed and rejected if they don't fit. But one of the important hypotheses that came out of the EMDR research that we did in Manchester in England was that there was an axis from the prefrontal cortex to the midbrain that was activated by eye movements or the tactile bilateral stimulation, or in the case that we studied in the scanner, the auditory bilateral stimulation. So that suggested to me that what was happening when EMDR was overwhelming for people was that we got into this axis from the prefrontal cortex to the midbrain periaqueductal gray, but we intensified the linkage there and intensified the awareness of what was happening in the midbrain PAG. And because the PAG was at the basis of affects like fear and rage and grief and shame, and also was involved in all the defensive responses that you would see in trauma, flight and fight and freeze and so on, it seemed a reasonable hypothesis that when we were using EMDR, which was often extremely effective, but when we were using it and it became overwhelming, it was because we'd got into this axis and the PAG part of it overwhelmed the PFC part of it. So the feelings just came up and they were just too much. So there was a switch into overwhelm, can't do this, or a switch into a different self state, like a child state that held the terror, for example. So here we had this wonderful treatment for PTSD that worked for many people, but couldn't be applied sometimes in those who really needed it, and those with the most severe early life trauma who also had often the most intense suicidality. So that was really what led me to try to find ways of working with the trauma history that wasn't overwhelming. And so combining with sensory motor, using brain spotting, using a comprehensive resource model, which is particularly good for self states because they can be resourced before they're worked with. So different ways of trying to make this treatment safer and more effective. And so that led me into looking at slowing things down, trying to see what was happening in those moments where there was overwhelm, where I thought the PAG was coming online and being too active to be coped with. What was happening there, and were there ways to slow it down enough to be able to not have it overwhelm? And I suppose because of the work I'd done around brain spotting and the comprehensive resource model that had taken me into the anatomy of the superior colliculi of the midbrain as well as the PAG, then I became focused on what was happening in those steps from a stimulus that was activating, that was traumatizing, what happened from the superior colliculi into the PAG that was leading sometimes to this overactivity of the PAG and therefore the experience of emotional overwhelm and intolerable distress. So that was why I started to slow down, and it was around this time that a colleague had asked me to say what was happening in her brainstem when she had these freeze responses that kept repeating and repeating despite an extensive amount of work on it. So when we slowed it down, we saw, well, that's where you get the stimulus that triggers the freeze. That's when you see that visual stimulus, that then has to go through those layers of the colliculi to get into the PAG. So let's just slow that down and see what happens then and how your body's responding to that stimulus and how it gets into the activation of the dorsal PAG, which leads you into the fear and rage and grief and shame, and also the freeze response. But what we also saw was that she had progressed from that active freeze state into the lower arousal freeze state. So the limbs would go floppy and there would be a sense of tiredness coming in. So in terms of the PAG structure, we could see that it was going from dorsal PAG, the active flight and fight responses and freeze responses, down into the ventrolateral PAG and the immobility and the opioids coming in and the sense of tiredness and exhaustion. So the really important thing about doing this was that the freezes cleared. So it seemed to be that just having slowed them down in this way, let's slow it down, let's see what's happening at the molecular level, let's see then what's happening at the dorsal PAG level, and then or notice how the ventrolateral PAG is coming online, because you're telling me that your heart rate has just dropped, and I notice that your breathing is almost imperceptible, and you tell me that your muscles have gone floppy. So we were tracking all through there, and being able to do that was enough to alter the freeze responses that had been established very, very early in life. So that was one of the things that was pretty instrumental in the development of DBR. And the other one was in relation to attachment shock. And it was looking for a way to get into attachment shock that was not based in a self state. But so if we tried self state work on it, nothing was shifting. All the affects appeared to have been processed. So what was going on, that there was still the intense activation that was causing activation of the upper brain and rumination and insomnia. What was the shock there? And when we slowed this one down, we found we could pick up the activating stimulus. We could see the passage almost through the layers of the superior colliculi, but instead of getting into the dorsal PAG and the affects, we were seeing a sudden body response. So the head would go back, the shoulders would brace, there was a flash of sensation through the body. So that looked then as though the shock was coming in before the affects, before the defensive responses. How to explain that? When I looked at the literature around that, there was the paper from Liddell et al. 2005 showing very fast responses to stimuli of only 17 milliseconds or thereabout. And there was an activation through the superior colliculi and the amygdala into the locus ceruleus. The wiring of the locus ceruleus suggests that could be the source of the shock activation. So we constructed the theory on the basis that the shock would hit the body in a sense before the thinking brain caught up, before the feeling brain even caught up, because there's no affect yet activated. And it looks as though we can have these shock responses probably within 100 milliseconds, maybe even 50. So they're so fast, they're easily missed. And they're so fast, it's easy then to go into the affect that takes over, because who doesn't get distracted by being terrified? You're not going to think about whether your shoulders are braced. You're going to think about the terror and what to do about that. So we slowed that down and notice what happens in the body in that moment when your shoulders go rigid and your head goes back and you've got that sudden empty feeling flash through your body. And similarly, the attachment shock cleared with that slowing down and focusing on the sequence. So,
Frank, how did you identify this attachment shock as attachment shock as opposed to trauma, brutalizing shock? Because they're often, I mean, in the patients you're describing, both are happening.
yeah, I think the first experience of studying it was clear attachment shock because it involved a person who had been hitherto loving and warm, suddenly changing and becoming critical, humiliating with no warning. So it was clearly an interactional or relational shock that was coming in there. There hadn't been any event that would have explained it, but it was the sudden impact of that, the unexpected, humiliating criticism that had not cleared despite attention to self-states, to affects, to defense responses. The activation of that moment of shock was still held by the body. So getting back to that and then slowing it down allowed that to clear also. So I started then talking about attachment shock. I think partly in discussion with 𝙏𝙗𝙚, who had a lot of knowledge about attachment science, and we talked a bit about attachment shock then, but also I noticed then that the shock was occurring in other situations, so that if somebody was in an earthquake, for example, the body could react before the affects came in and the thinking brain caught up. And also for interpersonal assaults and so on that came out of the blue, there was these moments of shock that were important to pick up, slow down, allow to clear, to allow the rest of whatever event it was to then resolve.
It seems to me that the whole field of concentration on developmental trauma or complex trauma is turning, and not so slowly, toward attachment, rupture, or failure as the core issue. But what I'm hearing you say, I just want to make sure I've got it right, is that this came to you mostly through a case, right? That you were, of someone you were working with,
Yeah.
where that became clear, and now when you pay attention to it, it's usually there. Do you think it's always there? I mean, I've heard you talk about you won't always see shock. So
yeah, I don't think it's always there. Sometimes it's a straight transition from the orienting to the activating stimulus into the affects and the defensive responses. But I'm now emphasizing the shock much more because it's so important to pick it up when it's there. And if we ask about it and it's not there, people will say, that's not there, but I'm feeling the terror or the rage, and that's fine. But as long as we ask about it, look for it, I think, because it's so fast, it's so easy to miss, but it's clinically of such significance, we have to try to look for it to make sure that we pick it up if it is there.
I just have one other thought about this, is that I wondered about the whole notion of slowing this down, which is clearly a major part of what you're teaching. And that in my little bit of experience with DBR, I have wondered about whether the slowing it down has to do with capturing a moment that goes by very quickly, which is, I think, what you emphasize, and or whether it is in itself doing something to calming, quieting, changing the reactivity of the brainstem. And I just wondered what your thoughts were on that.
Yeah, I do think that the slowing it down deconsolidates the body memory. And I think getting it into the sequence in which it was established, there's a kind of coherence about it, I think, that makes it more understandable to the person's brain, but also it it deconsolidates the body memory and makes it amenable to change. So I do think that the slowing down enough probably does offer some regulation. It does offer some reduction in reactivity, but it also makes the body memory available for transformation.
And then in that, you're often guiding that slowing down. As the therapist is often guiding that, right? This is what you call being directive, right?
Yeah.
Okay. So this is the other thing, and before we talk a little bit about neurofeedback, is what's the therapist doing here? What's the interpersonal what's the therapist doing here in your mind? I mean, this is a very neurologically based understanding, right? This is a very brain-based understanding. But the therapist is vital in this process. And I just wonder how your thoughts about that.
Yeah, I think the therapist will have the best attunement to the patient's experience if working with the neuroanatomy and tracking through the neuroanatomical structures, because it allows a level of attunement with the slowed down sequence which wouldn't otherwise be available. And sometimes people want to just take it as a protocol. They want to just say, yeah, all you need to do is find the orienting tension and then just wait for things to get better. I don't think there is the same level of attunement if it's just a matter of using an orienting tension as an anchor and as a file opener, and then letting it happen without trying to understand what's going on. And that understanding of the shock, here we've got the shock, this is what you're experiencing, or here we've got the freeze, we can see your dorsal PAGs come online there with the terror, or here we've got that collapsed immobility state and you're getting drowsy. My view is that the ability to relate to the anatomical structures gives a level of attunement which you don't get if you're just tracking at a kind of outward level or at a sensation level even. I think being able to put the reports against the neuroanatomy deepens the attunement of the therapist and the patient, and it gives a level of attunement that you wouldn't otherwise achieve, I don't think, because, when else is somebody going to be interested in the brainstem activity and slowing it down to, to such a degree to pick up these points? But they're points at crucial moments of people's lives, and there can be horrific histories, but, many times it comes down to particular moments of absolute horror and shock, and getting into those moments and being able to attune to them, be with them, allows transformation, I think, that then has a beneficial effect on the rest of the history of trauma in the person's early life.
It also, it's the nature of the attunement, I think. I just want your thoughts on this too. But the nature of the attunement is also extremely destigmatizing, right? It's really what you're saying is, oh, this is actually something that's going on in your brain and that we want to understand and interrupt, right? We want to slow it down. It is kind of an interruption, right?
Yeah, okay, yeah.
No, I mean, I'm asking. I'm not saying. I don't, either one.
Yeah, yeah, yeah. We don't want to interrupt the sequence in the sense of trying to divert it in another direction, but I think we are interrupting the fast flow of it, because these things that are happening in milliseconds can just shoot through so quickly that we miss the most salient moments of them. So we're trying to slow it down by interrupting sometimes and just making sure it's slow and we can get each component of the sequence.
But, when shame is such a major factor, which it always is in developmental trauma, it feels to me that if the nature of the therapist's attunement is about saying, this is happening in your brain, I think this is what you're saying, right? This is happening in your brain. Notice what's happening in your brain. That those feelings have brain behind them, brainstem, right? You corrected one time. I said, this is the brain. You said, no, Sebern, this is the brainstem. That it is, that changes the whole nature of the conversation.
Yeah, I missed your point about the destigmatizing, so just to emphasize it is very destigmatizing because it's so factual. Or yeah, I mean, you change the wording according to who's doing the work, but you're essentially saying, oh yeah, no wonder you were terrified. That's your dorsal PAG activated in that situation, and look how terrified you were because there's some numbing coming in, which is probably some cannabinoid saying, this is getting a bit extreme here. Let's cap this so that your heart rate doesn't go off the scale. So that's very destigmatizing. It's very explanatory of the body responses that happened in the trauma situations, I think.
Yeah, it's not your character. It's not that you're damaged. And it's not even your mind in a certain way, right? It's a profound shift.
Yeah.
How to think about all of this.
Yeah.
I wonder if I can ask about something sort of, I guess it seems like it's simple, but I think it's kind of radical, and it's a piece that I think resonates for example, people who do bottom-up therapy, like eager neurofeedback clinicians. This idea that the brain is motivated by its own self-regulation. That's the goal. And I've heard you in an interview before say the brain knows best. And I wonder, it occurred to me when I was hearing you talk about that, is there neuroscience evidence for this idea that the brain actually wants to find the most efficient and least, safest, as you've said before, way of healing itself, of clearing the trauma, and so on?
Right. I don't think there's neuroscience evidence for it, unfortunately. I would love to know what happens in the brain during those times when the healing is progressing in the brain, often in silence, when something is happening, which I think must involve not just the brainstem, but its connections with the upper levels. So I'm pretty sure that the lower circuitry and the upper thalamocortical circuitry are involved during those times when processing is flowing, and we're sitting with it. So for some reason, it seems that, I think anyway, that when we get the sequence at brainstem level, we're overcoming a block to the natural healing, the natural processing that has been impaired, perhaps because of shock or affective intensity and neurochemical dissociation. For whatever reason, we're able to slow it down enough to not have those turning away tendencies come in automatically, and we're able to allow the healing process that has been obstructed, we're allowing that to flow and allowing it to complete. So all of those things like shock responses, neurochemical dissociation, structural dissociation, turning away, all of them are essential at the time of the trauma for survival, but 20 years later, 30 years later, it may be that they're blocking the healing. And so we're going back into pathways that have been established in early life, and we're giving the opportunity for them to clear so that they find and they overcome the obstructions, and then the natural healing itself gets a chance to flow.
Part of what seems so deeply radical, really, about the DBR approach that resonates, for me as somebody who's working with neurofeedback clinicians, is this idea that that the therapist is really a guide, is really trying to enable the healing process to happen naturally within the person. And I wonder, part of what I think is asked of therapists and clinicians who start to do this work is to become comfortable with the ambiguity. In one interview, you talked about when you don't even know what's going on in the person's brain and you're just present there with it. Can you talk about what kinds of things, how does a therapist approach it in this way? Because it's really a strong paradigm shift from a kind of medical model of mental illness, right?
And it's often difficult for therapists who are used to doing something, that will produce betterness in the patient or client. It's difficult to accept that it may be at times best to set up the session in a way that then allows it to flow spontaneously, and that we as therapists have to acknowledge that the person's brain is going to do the important work. We're important for setting it up and being with it and witnessing it and helping out if there are blocks or just being present with it. So we've got our importance as therapists, but it's often not by doing something of it as an intervention. It's not having a clever cognitive restructuring coming in. It's been able to accept what's coming through and allow it to develop.
You've also talked about this, that sometimes as people begin to clear this trauma, they experience this process of healing. Sometimes what happens for them is a sort of surfacing of their sense of horror of all of the other things that have happened in their life that have been painful or traumatizing. I wonder if you could talk a little bit about what you see is happening, in that process for somebody who's clearing that, because I think this is part of the interesting and really difficult to grasp, for me at least, is that this is really a verbal exchange that's happening between a therapist and the survivor, and yet what we're talking about is something that is happening on a deep neurophysiological level.
Yeah, sorry, I got sidetracked there last, just trying to work out my answer. Can you give me that again?
Sure. So,
Yeah.
the starting place was thinking about how, as somebody begins to clear their attachment rupture, they become more aware. This is part of what you've talked about, is that, although the processing part may actually be minimal, it may lead to increased confidence and a sense of awareness of their body and so on. But then they also become aware of this history of trauma.
Yeah, and I think sometimes that there can be a shock at the realization of what happened, and that's why we need to be careful with DBR, as with any other trauma therapy. And that's why I think we often need to be going very slowly too, and how we approach the trauma history, because that there can be a realization and a real, oh no, that actually happened. That's not my imagination. That's not, something that I've been talking about without really believing it. I can feel it. I know it happened. And so there can be a shock and horror at the shocking horrors that have happened in early life. And we need to be aware of that possibility. And sometimes we use that shock as a way into further processing, further healing. So it does reinforce the need to do this carefully, cautiously, always, acknowledging that some of what's there may be very shocking and horrifying and difficult to be with. And I think that's where the combination with neurofeedback will be particularly important, because if there are ways in which individuals can do a piece of processing and then have their brain regulated by neurofeedback before the next session when they do more processing, then it's going to be more comfortable and it's going to be safer and it's going to be more complete in the long run. So one of my hopes for this collaboration of DBR and neurofeedback is that it'll provide a way of working that's much easier for people to tolerate while being, as it moves towards completion.
I think that, thank you, Frank. I agree with you completely. And I think the one thing that it's almost becoming another saying, right? Attachment rupture, without really acknowledging, and even saying that's at the center of everything. It's not really acknowledging the core issue of that, and that everything else that happens may be secondary in level of importance to the individual, but it gets the attention. When we talk about horror and even most shock, as you're talking about it, we're not talking about the moment the mother turns away. We're talking about all of the beating or the horror. All other of the other things. And that it feels to me that the real promise, the distinctive promise of DBR is around healing this attachment. And that the rest of it, maybe it's the arousal from the rest of it, or the sheer terror that many people live in with these histories for their lives. It can be eased, quieted, that the affect of the PAG part of this neurofeedback may be even more effective with, or can be helpful with. The attachment part, it feels to me like, I don't know that there are people that neuroscience talks about an attachment system, but you are safe in saying that we are born for it, right? We are born to turn toward our mothers. That's the superior colliculus, right? Turn the head toward the mother. And if the mother turns away, the mother in a generic sense, because this could be obviously a father, a caretaker.
Sure. Yeah.
That's the catastrophe. That's the fundamental catastrophe of the nervous system. And that's, I think, what DBR is focused on in a way that is unique. That's my thought on it anyway.
And one of the ways that we're looking at it differently, I think, is by stressing how painful that must be for an infant in that moment of shock, horror, turning away. And depending on the suddenness of it, there'll be some correlation, I think, with the intensity of the pain or the degree of shock involved. But I would argue that however it happens, there must be some internal pain, there must be some internal experience of wounding that the attempt at connection through the colliculi and the stimulus the sensory motor transformation of the stimulus and the interaction with the mother, there's something in that is not met, and it's painful, and there's a deep pain inside. And it's that pain then, I think, that can fire up the PHE to, to produce sadness or fear or shame or rage. So we can then have that deep internal pain that doesn't get to conscious levels. So it's the most deep unconscious wound, I think, that's possible to carry, that's held, deep in body structures, deep in neural structures, evolutionarily old pathways that register the aloneness, the lack of attunement, the lack of mirroring, the lack of responsive sensory interaction. Something inside registers that, and it doesn't readily get to cortical level consciousness. So we're working with this deep wound, this deep pain, and the affects that come from it.
And of course, this, in traditional ways of looking at the disorders, right? This gets played out in the transference. This gets played out on a huge and terrible canvas in interpersonal relationships for the rest of somebody's life, and it's very hard to surface. Right? It's very hard, from what you're saying. This is so deep in the brain. It's so deep in the unconscious, but the brain then is the source of the unconscious, right? This brain pattern then becomes the source of the unconscious, that it can be interpreted, it can be medicated, it can be whatever we've done, and you won't get to it.
No.
Yeah.
And if you think that the colliculi are able to approach, to capture either prey or the attention of a significant other, and they're also able to turn away. So different parts of the colliculi are involved in the approach to capture the attention of the other or the turning away to defend. So you can have that fundamental attachment conflict held at that upper brainstem level, so far below thalamus and cortex, that you'll never get to it with thinking or other ways of approaching it. You have to get down into the unconscious roots of it and pick up these turning towards, turning away tendencies based in the brainstem.
I wonder, could I ask about to go back to the sort of stigma idea? One of the things that comes up sometimes in discussion with clinicians is the way that a diagnosis often leads to a sense of, I have a static condition. And some of what you've been describing here, it suggests to me that there's an underlying understanding that it's not about the content of what episodic memory may show about what actually happened in a situation. It's not even about the affect of like what the emotional content of it, what the person feels in terms of grief and rage and fear and so on, shame. But that underneath there's a kind of neurophysiological shock response that you can access. And I guess the place where that I become very curious is, it seems that you prioritize this idea of safety in the therapeutic process, that it's extremely important for the person who is processing this stuff to feel safe in that process, and that you're able to do that by actually saying, we don't actually need it. I've heard you say this explicitly. We don't need to talk about the actual content of what happened in your memory, or for you to process, the feelings that you have around that stuff. I wonder if you could talk about that sense of safety and processing.
Yeah, and one of the reasons that I think we're below diagnosis as well as below parts of self and below upper level functioning is that we're looking at a lot of disorders that present in different ways as arising from early attachment experiences of shock and horror and pain, and then the different dysregulating responses that arise from that internal experience of pain, and how it is that some people have gone into a switch off from it and have coped by not being in contact at all with the pain, but feel that they have a fundamental numbing out in their life, whereas others are emotionally dysregulated and readily go into activated affective states. So whatever the upper level manifestation, we're really looking for these lower level experiences of pain and shock and affective responses. And I think it's essential that the person feels safe in the therapeutic transaction. The person feels safe so that they feel able to go into the deep wounds and pains without fear of further humiliation, for example, or further shock or dismissal or judgment. So, and I hope it's also easier for therapists who are using this model to be able to say, oh yeah, I can see we've gone into the dorsal PAG. That's why this person is raging, and look at where it comes in the sequence. It's just after we talked about the pain of aloneness. So we can follow that and we can track it. And then there's no judgment about why the person has suddenly got angry, and there's no need to interpret it. We're just with it and giving it space and time, and the space and time and the safety and the sessions, I think, are extremely important.
Can I just say that it's also, you have said that the PAG has the capacity for reception of kindness and generate joy. And I think that it's not just a facilitation process. There is a tone, right? And I see it in every interview with you and every demonstration with you. There is an enormous, it's both that you are attentive to the individual and not to the sort of routineness of the process, but to the uniqueness of the individual at the same time as talking about the sort of routine, I mean, if you can call this routine, but it's always with enormous kindness. And I just think that that's not talked about in therapy particularly. The nature of kindness. And this too is sounding like there's a neurological component to it that's pretty important. So would you talk about that for a second?
Yeah, I think you're right. And I think when we're going as therapists down to molecular level at the start of a session, when we're making sure that we're also grounded and present and attentive to the other, I hope that it gives space for the positive affects of care and nurturing particularly to come through and to dominate the affective landscape of the therapist during the session, so that there's no fear or rage or grief or shame coming to the surface in the therapist. It would just be the attention with care and nurturing and kindness, so that the positive affect state is there in the background through the session. And I'm sure that facilitates the healing process in the patient or client, because that person has got, by definition, all of those negative affects coming through, and we're able to be with it and not be fazed by it, and be able to care about the intensity of the experience and be able to care about how it can be transformed. And it doesn't need any interpretation, of transference or anything, because it's just that basic being with with kindness and attention, and and that I think allows the session to flow most effectively.
But it's also, I think, inherently what I'm hearing you say is that it is protective of the therapist as well as the patient, right? Because these are intense affects that are flowing through, right? And we are affected by those. Or if we're not affected by them, we're numbing out, right? So this is also this is also one of the reasons that I recommend neurofeedback. The therapists who have neurofeedback do neurofeedback for themselves, that they investigate, inquire, and care about their own brains, right? It's because this is an intense field to enter. And I think by the way that you're describing it, and again, some experience that I've had, it feels like, there is you're protecting everybody in this process from that field of powerful experience and affect.
Well, thank you for that, Sebern.
Thank you, Frank. You're muted, Lars.
Okay. How about now?
You're good.
I wonder if you could talk a little bit about the ongoing research with DBR. I understand that you have been doing some work with Dr. Lanius, Dr. Ruth Lanius, and maybe I got a sense, did you write a book with her brother?
Yeah, some years ago, wrote a book with Ulrich Lanius and Sandra Paulson. So that was a book that was into the PAG from an EMDR and sensory motor perspective mainly. So yes, I've known Ruth and her brother Ulrich for a number of years, and was delighted when Ruth was able to organise a clinical and neuroimaging study of DBR in London, Ontario. And the first results have come through. It's an interim analysis of the first 23 patients who had 8 sessions of online DBR, and they've been compared with people who were on the waiting list, 23 people who were on the waiting list. The important thing from a scientific point of view is that the rating was done blind to conditions, so the raters didn't know if people had had DBR or not, and the patients were instructed to keep it quiet if whichever condition they were in. But there's a large effect size after the 8 sessions of online DBR. And also nice was that 3 months later, the effect size for the difference between the patients and the controls was even larger. So it looked as though what was gained during those 8 sessions led to continuing improvement after the 8 sessions, which is extremely encouraging. That's been written up and there's a paper been submitted, so can't say any more just yet, but hope it will be available for citation before too long. Oh, and the other thing, of course, is that there's also the neuroimaging piece of it. So that was disrupted by the pandemic, and we don't have a full cohort of 23 versus 23 for the neuroimaging. So we're collecting some more to get larger numbers before looking at the brainstem connectivity and the differences between those who've had the effective treatment and those who've been on the waiting list.
That's great. Thank you so much for taking the time to talk with us today, Dr. Corrigan. Sebern, do you have any last thoughts or?
Well, this may be premature, but I don't think so. I sense that DBR is the therapy or has to be incorporated into the therapy, and that and neurofeedback together are so there's a so whatever school of therapy you come from, you could embrace DBR and you can embrace neurofeedback. And I think that DBR and neurofeedback are the future of, and hopefully the near future of, treatment for early childhood attachment catastrophe and trauma. So yeah, that's what I think. And I am so glad to have lived long enough to see this. So thank you, Frank. It was wonderful to have this conversation. I hope it's up on every website in the world. So, let's do that.
Thank you both very much for the opportunity. Thank you.